welcome to the deep dive. You've sent us quite the stack of information here, a whole load of PDFs, all focused on equine health.
It's a really comprehensive set, yeah.
Absolutely. We've got stuff covering colic, lameness, toxicology, neurology, cardiology, even general nursing care, lab samples, meds.
Preventative medicine, common problems, full diarrheas. It's quite the range.
It really is. So our mission today is to kind of sift through all this, pull out the most crucial bits, the surprising insights.
Give you a shortcut, essentially.
Exactly. So you get the key concepts without feeling totally buried in detail.
Okay, let's jump right in with something that really stood out to me from your sources.
Go on.
A massive 90% of all lameness in horses actually starts in the foot.
That's a huge statistic, and it really underlines the foot's importance. Lameness, as your materials clearly show, is just such a common problem.
The #1 reason horses get retired or sold, apparently.
It is. And the AAEP, the American Association of Equine Practitioners, they have this lameness scale, grades 1 to 5. It helps standardize things. Right, so everyone knows what we're talking about. Grade 1 is super subtle.
Yeah, maybe only noticeable under specific conditions, like on a certain surface or during a specific maneuver.
And grade 5 is?
Non-weight bearing. The horse just won't put that foot down. Obvious severe pain.
I found that down-on sound mnemonic really helpful for forelimb lameness. The head goes up on the lame leg, down on the sound one.
It's a classic observation, very useful. Hind limb lameness, though. That can be trickier to spot sometimes.
Yeah, the head bob isn't always there, is it? You're looking more at the hip.
Exactly. You're often watching for more movement, like a hike, in the point of the tuber sacrale on the lame side when it bears weight. And it drops more when the sound leg takes the weight.
Okay.
Sometimes, with really bad hind limb lameness, you might even get a head bob on the opposite forelimb, which can confuse things.
But across all these sources, for lameness and, well, pretty much everything, that detailed history seems absolutely vital.
Oh, completely. You have to ask, when did it start? Suddenly? Gradually?
Has it happened before? What's the horse's job? Shoeing history.
What makes it worse? What makes it better? All that detective work, as you call it, is fundamental.
And then the actual exam. Just watching the horse move tells you so much, right?
Absolutely. Walk, trot, sometimes canter, straight lines, circles on a lunge line.
Hard ground, soft ground.
You get a much fuller picture. Then you get your hands on them palpation, feeling for heat, pain, any swelling fluid.
Comparing side to side.
Always compare. Check the limbs, joints, tendons, ligaments, even the neck and back. Look for muscle loss, stride length differences, wounds, how they stand, hoof wear.
In those flexion tests, holding the joint bent.
Crucial. And hoof testers, applying that specific pressure to the sole and frog, really helps narrow things down, especially with foot pain.
Now, there were some important warnings in your notes, like don't force movement if it's really bad lameness or you think there might be a fracture.
Definitely not. And avoid nerve blocks if you suspect a fracture. You don't want the horse suddenly feeling good enough to use a broken bone.
Makes sense. But those nerve blocks, the regional anesthesia, they're key for pinpointing the pain source otherwise.
Incredibly valuable. We numb specific nerves, starting low down on the leg, usually the foot, and see if the lameness improves or disappears.
And the different drugs last different amounts of time. Lidocaine is quick.
Right. Lidocaine wears off in maybe 30, 45 minutes. Good for a quick check of the foot. Mepivacaine lasts longer, maybe 90 minutes to 2 hours.
Gives you more time to evaluate.
Yeah. And bupivacaine can last 4 to 6 hours, useful for longer blocks or pain management. If blocking a certain nerve fixes the lameness, you know the problem is in the area supplied by that nerve, or below it.
And for seeing inside, x-rays for bone.
Radiography, yes. Still the best for bone lesions. You always need at least 2 views, usually more.
And ultrasound for soft tissues, tendons and ligaments.
Exactly. Ultrasound is excellent for that.
It's interesting how lameness connects to some of the other things in these documents. Laminitis, for example.
Yeah, laminitis can be traumatic, metabolic, but also toxic, like from black walnut shavings or wilted red maple leaves. We'll get to those toxins.
Osteoarthritis shows up on x-rays. Fractures, obviously traumatic, cause severe lameness.
And infections are a big one. Foot abscesses are super common, often cause severe lameness. Hoof testers are usually positive, and you might feel a strong pulse, a bounding digital pulse.
Septic joints or tendon sheaths, too. Also infectious.
Yes, very serious. You'll often see significant swelling of the joint or sheath itself that's a fusion. Cellulitis or lymphangitis cause massive limb swelling, heat, fever, and severe lameness.
Then there are muscle issues, myopathies, and those neurological conditions. EDM and EMND.
Equine degenerative myelencephalopathy and equine motor neuron disease linked to vitamin E deficiency can cause progressive weakness or lameness-like signs.
So if a horse is grade 4 or 5 lame, really struggling.
You're thinking foot abscess, septic joint or tendon sheath, cellulitis, lymphangitis, or a fracture, maybe a bad suspensory ligament injury. Those are often the top culprits for severe acute lameness.
Okay, let's switch gears to another major emergency call. Colic.
Ah, yes. Abdominal pain. A very frequent reason for a vet visit, often an emergency.
What are those classic signs you'd see in the sources? Rolling.
Rolling, definitely. Pawing the ground, looking back at their flank, maybe kicking at their belly, loss of appetite, decreased manure production.
Elevated heart rate. Breathing fast.
Tachycardia and tachypnea, yes. And in severe cases, signs of shock, pale gums, maybe sweaty, trembling.
So how does a vet figure out what's causing the colic? What are the key diagnostic steps?
It starts with a good physical exam, assessing the pain level, listening for gut sounds. Are they increased, decreased, absent? Checking heart rate, respiratory rate, gum color, hydration status.
Rectal palpation must be important.
It can be very informative, yes. Feeling for distended loops of bowel, impactions, displaced organs. It gives us an idea of what's happening inside, though you can only feel the back part of the abdomen.
And the nasogastric tube. Passing a tube down the nose into the stomach.
Absolutely critical. Horses can't vomit, so if there's fluid buildup in the stomach or small intestine, it needs to be removed. Getting more than 2 liters of fluid-back reflux is generally abnormal and suggests a blockage or issue further down.
Ultrasound is used too.
Abdominal ultrasound is fantastic. We can look at the intestinal walls, see if they're thickened, assess motility, how well things are moving, look for distension, free fluid in the abdomen.
And sometimes taking a fluid sample from the belly. Abdominocentesis.
Right, the belly tap. Analyzing that fluid can give huge clues. If it's cloudy, bloody, has high protein or lactate levels, that often points towards compromised bowel and likely the need for surgery.
And initial treatment often involves pain relief.
Yes, analgesics are key. Sometimes drugs to relax the gut spasm, like Buscopan. Passing that NG tube provides decompression, and IV fluids are crucial if they're dehydrated or showing signs of shock.
Then it comes down to that big decision. Medical management or surgery.
Exactly. Some colics respond well to medical treatment, others absolutely require surgery to fix the underlying problem. The diagnostics help us make that call.
Your sources listed quite a few specific types of colic. Proximal enteritis, for instance, that's usually medical.
Typically, yes. It's inflammation of the upper small intestine. Horses are often quite depressed, maybe a mild fever, mild colic signs. The hallmark is usually lots of that reflux through the NG tube, often reddish-brown and smelly. Ultrasound might show thick-walled, sluggish small intestine.
Large colon impactions, also medical.
Often, yes, usually milder, intermittent colic. You can often feel the firm mass of feed in the large colon during the rectal exam. Treatment involves fluids, often given through the NG tube, and laxatives like mineral oil or magnesium sulfate.
But then there are the really serious surgical ones. Large colon volvulus. That sounds bad.
It's a twist, and it's a critical emergency. Very sudden, severe pain, often unresponsive to pain meds. The horse gets very distended, heart rate shoots way up. Ultrasound often shows a very thickened colon wall. Needs surgery fast.
Small intestinal strangulation or incarceration too, also surgical.
Definitely surgical. This is where a piece of small intestine gets trapped, cutting off its blood supply. Pain is often progressive and severe, lots of reflux. The horse deteriorates quickly metabolically. Rectal and ultrasound might show distended loops of small intestine. The belly tap fluid is often serosanguineous, blunt-tinged with high lactate.
And large colon displacements, left or right dorsal.
These involve the colon shifting out of its normal position, can cause mild to moderate, sometimes recurrent colic, often with distension. Rectal and ultrasound findings are specific for each type. Left displacements can sometimes be corrected medically, maybe with medication and exercise, but right displacements or persistent left ones usually need surgery.
The list goes on in your notes. Gastric ulcers can cause colic signs.
Very common, especially in performance horses. Diagnosed with gastroscopy, putting a camera down into the stomach.
Colitis, inflammation of the colon.
Can present with colic, but often also diarrhea, fever, dehydration. Diagnosed with fecal tests, ultrasound, blood work.
Parasites, fecaliths in minis, lipomas in older horses, enteroliths in certain breeds.
Yep, all potential causes. Fecaliths are hard manure balls. Lipomas are fatty tumors on stalks that can wrap around intestine. Enteroliths are stones that form in the gut, especially common in Arabians or horses on alfalfa hay.
And even NSAA toxicity can cause colic.
Yes, through gastric and colonic ulceration, which leads us nicely into toxicology.
Right, the hidden dangers. What's the first step if you suspect poisoning?
History, history, history. Has anything changed? New feed, new pasture, access to something different? Are other animals affected? How quickly did the signs appear?
And check the environment.
Absolutely. Examine the feed, water source, pasture, any chemicals stored nearby. Collect samples if you can feed, water, plant material, blood, urine from the horse.
And if you think they've ingested something toxic recently, decontamination.
First, stabilize the horse if needed ABCs. Since they can't vomit, gastric lavage via NG tube might help if it was very recent. Activated charcoal is often given through the tube.
That binds the toxins.
Exactly, prevents absorption. Sometimes with a cathartic like magnesium sulfate to speed things up, but usually not with mineral oil if you've given charcoal. If it's skin exposure, lots of bathing with mild soap and water. And supportive care is key: IV fluids, pain relief.
Let's talk specifics from your sources. NSAID toxicity again.
Yeah, overuse or sensitivity to drugs like phenylbutazone or flunixin can cause those GI ulcers we mentioned, but also kidney damage, specifically renal medullary crest necrosis.
Signs being
Colic, diarrhea, poor appetite, weight loss, maybe ventral edema, swelling under the belly, sometimes increased drinking urination, possibly blood in urine. Blood work might show low protein, high kidney values. Gastroscopy can confirm ulcers.
red maple toxicity sounds scary.
Yeah.
Wilted leaves are the problem.
Yes, especially after a storm or in the fall. The toxin damages red blood cells, causing hemolytic anemia and methemoglobinemia. The blood can't carry oxygen properly.
So the horse would seem weak. Pale gums, dark urine.
Exactly. Weakness, rapid breathing, jaundice, yellow gums, reddish-brown urine due to hemoglobin can sometimes trigger laminitis or colic too. Blood tests confirm the anemia and specific red cell changes.
Black walnut, just the shavings, can cause laminitis.
Correct. Contact with or ingestion of black walnut wood, often embedding shavings, can cause acute, severe laminitis within hours. Warm hooves, shifting weight, reluctance to move, lymphedema.
Sycamore poisoning or atypical myopathy. That involves a specific toxin.
Hypoglycin A, found in the seeds, keys, and sometimes seedlings. It disrupts muscle energy metabolism, causing severe, non-exertional muscle damage, rhabdomyolysis.
So extreme weakness, muscle tremors, maybe unable to stand, dark urine.
Yes, very dark urine for myoglobin release. Often difficulty swallowing, may seem colicky but still want to eat. Muscle enzymes, CK, AST, will be sky high. Testing for hypoglycin A confirms it, often fatal.
And yellow star thistle or Russian knapweed affects chewing.
Causes a specific brain lesion, nigropalatal encephalomalacia. Affects the nerves controlling chewing. They get this involuntary continuous chewing motion, facial muscle rigidity, difficulty eating and drinking, leading to weight loss, usually from chronic ingestion when other forage is scarce. Poor prognosis.
White snake root. That has muscle and heart effects.
Yes, the toxin is trimetol. Causes muscle tremors, hence the name trembles, weakness, difficulty swallowing, sweating, potentially abnormal heart rhythms, heart failure. Sometimes a characteristic acetone-like smell on the breath, often from chronic low-level exposure.
Okay, wow. Let's move into the brain and nerves neurology. There's a grading scale here too, right? Like lameness.
Yes, similar concept. Grade 1 is very subtle deficits, maybe only seen with specific tests. Grade 5 is recumbent, unable to rise. Grades 2, 3, 4 are progressively worse in coordination and weakness.
EPM, equine protozoal myeloencephalitis seems like a big one.
It is, caused by protozoa, usually Sarcocystis neurona. The tricky thing is the signs are incredibly variable. Can be subtle gait issues, stumbling, muscle wasting.
Often asymmetric. Worse on one side.
Very often asymmetric, yes. Weakness, incoordination, sometimes sweating abnormalities, cranial nerve signs. Diagnosis relies on clinical signs plus testing blood and spinal fluid for antibody ratios. The SAG2-43 titer ratio is commonly used. Treatment involves antiprotozoal drugs like ponazuril.
Wobbler syndrome, cervical vertebral malformation, or CVM, that affects the neck.
Right. It's a narrowing of the spinal canal in the neck vertebrae, compressing the spinal cord, causes progressive ataxia, incoordination, and weakness, usually worse in the hind limbs.
More common in young, fast-growing horses.
Type I is, yes, often in thoroughbreds, quarter horses, warm bloods. Type 2 can occur in older horses due to arthritis. Diagnosis uses neck x-rays, sometimes myelography, contrast dye study. The SLAP test, checking the reflex laryngeal muscle contraction, is often abnormal.
And direct trauma to the brain or spine?
Unfortunately, yes. Falls, kicks, running into things. Signs depend entirely on the location of the injury. Forebrain injury might cause seizures, blindness, altered behavior. Brainstem injury affects balance, cranial nerves. Spinal cord injury causes ataxia, paralysis, incontinence. Imaging like X-rays, CT, or MRI helps diagnose.
Clostridial neurotoxins, botulism, and tetanus.
Mm.
Very different presentation.
Completely different. Botulism toxin causes flaccid paralysis, progressive weakness, difficulty swallowing, dysphagia, weak tongue, tail, eyelids, muscle tremors, often linked to contaminated feed, especially around bales, Shaker-Foal syndrome.
Yeah, and tetanus.
Tetanus toxin causes rigid paralysis, stiffness, sawhorse stance, elevated tail, difficulty eating, swallowing, flared nostrils, prolapsed third eyelid, extreme sensitivity to stimuli, usually from wound contamination. Vaccination is highly effective prevention for tetanus.
EHM, equine herpes myeloencephalopathy, that's virus-related.
Yes, caused by neuropathogenic strains of equine herpes virus 1, EHV1. Often sudden onset ataxia, weakness, especially hind limbs, urinary incontinence is common, can progress to recumbency. May see respiratory signs or abortions in other horses on the property. Diagnosis often involves PCR testing on nasal swabs or blood and CSF analysis.
Neonatal encephalopathy, or PAS, perinatal asphyxia syndrome, affects newborns.
Right, often called dummy foals or hypoxic ischemic encephalopathy. They seem normal at first, then develop signs hours later: lethargy, poor suckle reflex, aimless wandering, maybe seizures, blindness, thought to be due to oxygen deprivation around birth.
Vestibulopathy, problems with balance.
Yes, affecting the inner ear or brainstem balance centers. Classic signs are head tilt, nystagmus, involuntary eye movement, ataxia. Peripheral, inner ear nerve, might have facial paralysis too. Central brainstem might have vertical nystagmus, depression, various causes, ear infection, trauma, THO, tempohyoid osteoarthropathy.
Pauline raditicui affects the tail end.
Also called cauda equina neuritis. It's an inflammation of the nerves of the tail, anus, perineum, bladder, causes numbness, weakness, tail paralysis, incontinence. Can also affect cranial nerves. Cause isn't fully understood, possibly immune-mediated.
Meningitis, inflammation of the brain coverings.
More common in foals, often from bacterial infections spreading. Signs include fever, neck stiffness, hypersensitivity, lethargy, seizures. Diagnosed by analyzing cerebrospinal fluid, CSF, looking for high white cell counts and protein, and culturing bacteria.
Rabies, always fatal, always a concern.
Absolutely. Causes rapidly progressive neurological signs, often starting with behavior change, aggression, agitation, or depression, then paralysis, difficulty swallowing. Diagnosed post-mortem by examining brain tissue. Zoonotic risk is paramount.
Lyme disease, or neuroborreliosis, can cause neuroscience too.
It can, though it's debated how commonly. Potential signs include ataxia, cranial nerve deficits, uveitis, muscle tremors, lethargy, spinal pain. Diagnosis often involves testing for antibodies, like the C6 ELISA, combined with clinical signs and ruling out other causes. Treatment usually involves doxycycline or minocycline.
The mosquito-borne viruses, E, W, V, and West Nile.
These are the viral encephalitis, inflammation of the brain. EE, Eastern, is typically most severe, rapid onset fever, depression, severe neuroscience, high fatality. WE, Western, is usually milder. VE, Venezuelan, can also cause systemic signs like fever, colic. West Nile Virus, WNV, is often asymptomatic or mild fever, but can cause ataxia, often asymmetric, weakness, muscle tremors, facial nerve paralysis.
Diagnosis involves blood tests for antibodies, IgM ELISA.
Yes, IgM ELISA is good for recent infection. Paired titers can show rising antibody levels. Virus isolation or PCR might be possible early on or from tissues post-mortem. CSF analysis can also help. These are serious, and EWV are reportable diseases. WNV is also zoonotic. Vaccination is key for prevention.
Okay, let's shift to the heart. Cardiology. Atrial fibrillation, AF, seems like a key one in horses.
It's probably the most common significant arrhythmia we see, especially in athletic horses. It's that irregular rhythm. Can cause poor performance, exercise intolerance, sometimes weakness, or it might be found incidentally.
Diagnosed with ECG.
Yes, ECG is definitive. Treatment can involve medication like quinidine or sometimes electrical cardioversion to try and shock the heart back into a normal rhythm. There's also that potential link noted with gastric ulcers, maybe via vagal tone.
The sources also mention things like DCM, HCM, heartworm, but those seem more for dogs and cats.
Generally, yes. Dilated cardiomyopathy, hypertrophic cardiomyopathy, pericardial effusion, heartworm disease, while possible in horses, they are much less common or present differently than in small animals based on the focus of your materials.
So what heart issues are more common equine concerns? Heart block.
Yes, particularly second-degree AV block, which can even be normal in fit horses at rest, but higher-grade blocks, advanced second or third degree, where sick sinus syndrome can cause problems like fainting or exercise intolerance. Diagnosed with ECG, maybe a Holter monitor worn for 24 hours. Pacemakers are an option in some cases.
Congenital defects. Holes in the heart. Valve problems.
They occur, though, less frequently than acquired issues, things like VSDs, ventricular septal defects, PDAs, patent ductus arteriosus, valve stenosis, often picked up as murmurs in young horses. Echocardiography, heart ultrasound, is key for diagnosis. Some can be surgically or interventionally repaired.
And endocarditis. Infection on the heart valves.
Less common than in dogs, but serious when it happens. Often presents with fever, shifting leg lameness, a new or changing heart murmur, weight loss. Diagnosis involves echo and blood cultures. Requires long-term aggressive antibiotic therapy.
Moving towards general care. What are the basics for looking after a horse that's hospitalized?
It boils down to meeting their fundamental needs. Comfort, clean, dry, safe bedding and environment. Hygiene. Nutrition, making sure they're eating and drinking appropriately, maybe needing assistance or special diets. Elimination monitoring manure and urine output.
Safety, pain management.
Absolutely. Preventing further injury, managing pain effectively, and constant close monitoring TPR, temp, pulse, respiration, attitude, appetite, hydration, response to treatment. That vigilance is critical.
What about common lab samples vets take? Blood from the jugular.
That's the standard for CBC, chemistry panels, Coggins tests, things like that. Arterial blood is much less common. Nasal swabs are used for respiratory PCR tests, flu, herpes, strangles.
Urine, feces.
Urine often requires sedation to catheterize a mare or gelding. Feces for parasite checks, fecal cultures, PCR for diarrhea pathogens like salmonella or clostridium,
Belly taps, joint taps.
abdominocentesis for colic fluid, synoviocentesis or joint taps for lameness or suspected joint infections, less commonly tracheal washes or BALs for lower airway issues, CSF taps for neuro cases.
And giving meds. Lots of routes.
Many ways. Orally is common paste, powder and feed, liquid syringed in the mouth, nasogastric tube for fluids, electrolytes, mineral oil, activated charcoal,
Injections, IM, 4A.
intramuscular IM in the neck, pectorals, or hindquarters. Intravenous is very common, usually the jugular vein, often using catheters for repeated doses or fluids. Meds can also be given rectally, topically, like eye drops ointments, epidurally for hind end pain, or directly into joints, intra-articular. Subcutaneous is rarely used in adult horses.
Okay, finally, let's touch on foal diarrheas, a special challenge.
Definitely. Foals are much more vulnerable to dehydration and complications from diarrhea than adult horses. Your sources highlight the big 5 causes.
Clostridiosis is one, affects really young foals.
Yes, usually less than a week old, often caused by Clostridium perfringens or difficile, very sudden, often severe, sometimes hemorrhagic diarrhea. Foals get sick, fast depressed, colicky, shocky, high fatality rate. Diagnosis via fecal toxin tests or PCR.
Salmonellosis, also young foals.
Typically under a month old. Can cause severe diarrhea, fever, depression, dehydration, shock. Blood work often shows very low white blood cell counts. Neutropenia, diagnosed with fecal culture or PCR. And remember, salmonella is zoonotic, people can get it.
Rotavirus and coronavirus.
Common in foals under 2 months. Usually profuse, watery, smelly diarrhea, depression, not wanting to nurse. Generally self-limiting in about 4-7 days, but supportive care, fluids, is vital. Fecal tests can identify the virus. Highly contagious. There's a vaccine mares can get to help protect foals against rotavirus.
Lawsoniae intracellularis, that's later, around weaning age.
Right, typically 4-6 months old. Causes proliferative enteropathy, thickening of the intestinal wall. See weight loss, poor growth, diarrhea, sometimes ventral edema, bottle jaw, or belly swelling, low protein on blood work. Ultrasound shows thickened small intestine. Diagnosed with fecal PCR or blood serology, requires specific antibiotics.
And the last one, full heat diarrhea.
Ah, yes. Very common around 7-14 days of age, coinciding with the mare's first heat cycle post-foaling. Usually mild, self-limiting diarrhea. Foal is otherwise bright, alert, nursing well. Thought to be related to changes in the foal's gut flora as they start nibbling things, or maybe hormonal changes via the mare's milk. Generally no treatment needed besides keeping the hind end clean.
Wow. Okay, that covers an incredible amount of ground. This deep dive, using the sources you provided, Really shows just how complex and interconnected equine health is.
It absolutely does. So many systems involved, so many potential issues.
For me, I think one of the biggest takeaways is just the sheer variety of things that can cause colic or cause lameness. It's never just one simple answer, is it?
Rarely. It emphasizes how important that thorough diagnostic process is, the history, the exam, the tests. You have to systematically work through the possibilities.
Right. So this overview gives a great foundation, but clearly each of these areas, lameness, colic, neuro, tox, cardiology, full health, you could spend ages on each one.
Oh, easily. They're huge fields in themselves.
So thinking about all this complexity we've just discussed, what single aspect really stands out to you, the listener? What do you find most fascinating or maybe most concerning? And what other questions does it spark for you?
Yeah, it's worth thinking about. Maybe revisit those sources you sent. Focus on an area that caught your attention. Keep learning.
Definitely. Thank you so much for sharing all this information with us and for joining us on this really comprehensive deep dive into equine health.
It was fascinating to go through it. Thanks for having me.